Hello and welcome to eCancer TV. We're here in Paris at the 13th International Myeloma Workshop, and I'm delighted to introduce Dr. Prof Orlowski from MD Anderson Cancer Center. Dr. Orlowski, you chaired a very interesting symposium today, and I wondered if you could perhaps just sort of reflect on that symposium and pick out one or two of the key highlights.
We did, as you mentioned, a symposium earlier today looking in particular at the role of proteasome inhibitors in management of multiple myeloma. I think some of the highlights, Dr. Paul Richardson from the Dana-Farber gave a presentation about some of the upfront therapies that can be used now for patients who are not transplant candidates. And we know that these do much better than some of our older standards. And the newer standards of care would be combinations like melphalan with prednisone and thalidomide, melphalan with prednisone and lenalidomide, or melphalan prednisone with bortezomib. And he also talked a little bit about the use of maintenance therapy after the initial therapy, either with bortezomib and thalidomide or bortezomib with prednisone. And in general, I think the take-home message from all of the studies that were done is that with the incorporation of these novel drugs earlier, mainly as first-line therapy, followed by maintenance, patients have much better quality responses, meaning more complete responses, and that does seem to be translating into a better progression-free survival as well as overall survival.
Interesting. Okay.
After Dr. Richardson, Dr. Sonneveld gave a presentation, this time focusing on patients who were transplant candidates. So these would be somewhat younger and perhaps fitter patients. The message there was actually somewhat similar in that early incorporation of drugs like bortezomib as well as lenalidomide, and this would be in combinations like bortezomib with doxorubicin and dexamethasone, or bortezomib with thalidomide and dexamethasone, again seem to give better quality responses. And whereas with older combinations like VAD or thalidomide and dexamethasone, where the quality of the response before transplant didn't seem to matter after transplant because the high-dose therapy tended to equalize everybody afterwards, with these newer regimens, we know that people who do better prior to transplant also do better after transplant. And that, I think, provides a rationale to try to achieve a better quality response prior to transplantation. And many of us would now consider that some kind of combination with a proteasome inhibitor and an immunomodulatory drug, as well as a little bit of dexamethasone, would be the standard of care. And the only question is which of the combinations is best.
Sure. There was some discussion about the role of bortezomib, subcutaneous versus IV. Interesting that the efficacy seemed to be on par. I just wondered if you'd comment on that.
Yeah, a very good point. So Dr. Michel Delforge presented data from a randomized study. This was in the relapsed setting, not in the upfront setting, but patients got either the standard bortezomib dose on the day 1, 4, 8, and 11 schedule as an IV, or they got the same dose and the same schedule, but instead it was given subcutaneously. Really the only difference was that the drug was made up at a higher concentration so that a lower volume had to be injected under the skin. And the main endpoint was the response rate after 4 and 8 cycles, and data were also collected about the durability of these responses. And the very encouraging result was that the subcutaneous bortezomib had the same response rate and quality after either 4 or 8 cycles as did the IV, and the progression-free survival and overall survival were also identical. Even more encouraging, and to some extent surprising in a good way, was the fact that the subcutaneous bortezomib seemed to have a lower rate of peripheral neuropathy and maybe even a little bit less thrombocytopenia.
Quite encouraging.
Yep. And many people now are considering using subcutaneous bortezomib as part of some of these frontline regimens that I mentioned earlier, like bortezomib with melphalan and prednisone, or bortezomib with lenalidomide and dexamethasone. And some people are also considering using bortezomib subcutaneously once per week, predominantly because of some of the data from the Spanish and Italian studies that suggested that either starting with once a week bortezomib combinations or moving very quickly after 1 or 2 cycles to once a week bortezomib combinations gives you roughly equivalent activity and efficacy, but again, less neuropathy. And the hope would be that perhaps the same would be true with the subcutaneous approach, although it's important to note that as of right now, there are not yet any study data about subcutaneous bortezomib given once per week. So don't do this at home yet.
Although you've raised an interesting point, and there is some evidence that giving bortezomib at home is a reality, that potentially that could be, a treatment of choice in the future.
I think we certainly are hoping that things will move in that direction, although the study that was done, of course, administered bortezomib still in the clinic setting. But hopefully at some point, what will be able to happen is that we'll be able to dispense bortezomib in a way that either a nurse could visit home and give it to the patient there, or perhaps the patient could give it to themselves. Although again, to emphasize, that study has not yet been done, and there are still some challenges that would need to be overcome, such as to make sure that the bortezomib solution was going to be sterile for a long enough period that it would be safe to give at home.
Perhaps just one more question on bortezomib, and this time its role in combination with HDAC inhibitors. And perhaps you could just discuss briefly about the unfolded protein response and the significance of that.
Yep, definitely. It's a good question. Bortezomib is a very active drug and also very exciting because it seems to combine with a number of different drug classes. And there are a number of studies looking at HDAC inhibitors or histone deacetylase inhibitors, as you've mentioned, such as vorinostat or panobinostat. Part of the rationale for that is that when myeloma cells are exposed to bortezomib, what bortezomib does is it blocks protein digestion inside the cell. And you get accumulation of proteins that are toxic. So what myeloma cells try to do to survive is to put these toxic proteins all together into something called an agrosome, and therefore to try to put it in one place in the cell where it wouldn't cause damage to the rest of the cellular structures. It's kind of like taking your garbage and putting it into the garage because you don't want it in your house. And one of the proteins that's important in that is a histone deacetylase called HDAC6. And there are data that suggest that HDAC inhibitors block that agrosome formation and therefore make it more likely that these toxic proteins that bortezomib induces will kill the cancer cell. There probably are other ways that the drugs interact. They both, for example, induce production of what are called reactive oxygen species. Those are things we all try to fight off because we think that they contribute to aging, but in the setting of cancer, reactive oxygen species are actually sometimes good because they can damage the DNA in the cancer cell and cause their death. So we know in the laboratory if we combine HDAC inhibitors and proteasome inhibitors, the combination is what's called synergistic, which means the activity is better than the combination of either drug alone. And there are a number of clinical trials that hopefully will show that these HDAC inhibitors will add to bortezomib-based combinations. And also there are trials looking at HDAC inhibitors with second-generation proteasome inhibitors like carfilzomib. We're actually at MD Anderson about to start a study of carfilzomib with panobinostat, which is one of the HDAC inhibitors for patients with relapsed or refractory myeloma.
And perhaps just a final question. Obviously, a great deal of data being presented at this meeting and huge interest in novel therapies. You have an interest also in monoclonal antibodies and their potential role in multiple myeloma treatment. Could you perhaps comment on that?
Yeah, it's a good point again. I think that we need to try to use every kind of approach for therapy of myeloma that seems attractive. And in lymphomas as well as leukemias, our colleagues have had a number of monoclonal antibodies to use, but so far in myeloma, we don't yet have anything approved. But I think there are a couple different monoclonal antibodies coming. The benefit of these antibodies is that although they have to be given intravenously, so you can't take them as a pill, because they're much more targeted than small molecules, they often have a much better safety profile. And some of these look very attractive. One is called ciltuximab, which is an anti-interleukin-6 antibody. And we know that IL-6 is important in myeloma growth and survival, and it also helps the myeloma cells survive chemotherapy. So there has been a trial completed with bortezomib and ciltuximab versus just bortezomib alone for relapsed myeloma, and we're hoping that soon the data will be available to look at. If they were very positive, that could be the first approved antibody. And then another one I think we should be excited about is called elotuzumab, which reacts against a protein on the surface of myeloma cells and actually causes direct death of the myeloma cell by acting like a little flag for the immune system that causes NK or natural killer cells to come in and lyse or kill the myeloma cells. And the data with that drug, both in combination with bortezomib as well as with lenalidomide, look very attractive, and there are now phase 2 and phase 3 studies with those combinations, which hopefully will result in drug approvals in the near future.
Great. Well, a very positive way to end our discussion. Dr. Orlowski, thank you very much for your time.